Hi everyone, this is Dr. G. Saiti Datar, Team MDS CONQUER. So the next topic that I am going to discuss is the radiographic diagnosis. Okay, so what exactly do you mean by radiographic diagnosis? It's nothing but when a radiograph is being given to you, you have to interpret the radiograph, you have to get your findings and you have to give your diagnosis only based on the findings that you get from your radiograph. So that is nothing but the radiographic findings. It's not the final diagnosis, it's just the diagnosis based on the interpretation and the findings that you get in your radiograph. Okay, so anyways, we have got a little idea of the normal anatomical landmarks in our IOPA, in our OPJ, as well as little knowledge we have gained about the advanced imaging, right? So now how to interpret the abnormality. If you know the normal thing, then only you can interpret the abnormality, okay? So the principles of radiographic interpretation states that the abnormalities which are present or which are depicted in a radiograph have to be interpreted in 5 different steps. Okay, so the first one being the localize the abnormality. Okay, so you have to first know the position. So first step being you have to see whether the abnormality or whether something you have find something is wrong with your radiograph, it is not normal, whether it is localized or whether it is generalized, okay, whether it is single or whether it is multiple, as well as you have to see the size of the abnormality. And the position within the jaws is very important, the position. So whether the epicenter of the abnormality is in relation with the tooth or it's not in relation with the tooth. So it means whether it's odontogenic or whether it's non-odontogenic, or whether it is above the inferior alveolar canal or below the inferior alveolar canal. Okay, and when if it occurs in the maxilla, then you have to see the epicenter in relation with the maxillary sinus as well. Okay, so the first and the foremost step is you have to localize the abnormality and you have to find where exactly it is located, and you have to know the size, and you have to see whether it is single or multiple or whether it is involving more than one areas, like whether it's multifocal or all that. Okay, so that is being the very first step of interpreting a radiograph. Next, coming to the second step is the assess the periphery and the shape. Okay, so whether the margins of the abnormality is well defined or ill defined. Okay, so if it is well defined, again it could be radio opaque margin or a radiolucent margin. Okay, if it is again radio opaque, the margin could be corticated or sclerotic. Okay, so the corticated margins are usually thin and uniform, whereas sclerotic margins is nothing but they are wide and they are not that uniform. Okay, so that is a major difference. So if it is thin and uniform, it is corticated, and if it is wide and if it is not that uniform, then you call it as sclerotic. Okay, and then if it is a radiolucent thin line, okay, which like a thin black line around a radio opacity or around an abnormality, if you find it, then it indicates, most commonly it indicates that it is a soft tissue capsule. Okay, so that capsule usually is found with odontomas or cementoblastomas and all that. You can find a thin radiolucent line. So that is nothing but a soft tissue capsule. So these are nothing but it comes under well defined margins. Next thing is the ill-defined. So ill-defined or invasive margins commonly seen with severe or aggressive tumors, and also it can be seen with malignancies. Okay, so that is the second step. So second step, we assess the periphery and the shape. Third step, we have to assess the internal structure. Okay, so internal structure, whether there are any septae present, whether is there air present. Okay, if it is maxillary sinus, we have to see it whether it's completely radiolucent or not. If there is haziness or if there is some radio opacity, then it indicates that there is sinusitis, right? So you have to look for conditions like whether there is air present or whether the bony trabeculae, how are they present, whether there are any septae present. Okay, the septae usually they can be, if it is a tumor, it can be as a honeycomb or soap bubble, right? We will be discussing that again in assistant tumors. Okay, there is a separate video based on image based discussion on assistant tumors. You can go ahead with that. Okay. And again you have to see whether there is any tooth present within the internal structure or any other metal present within the internal structure. So metal will be very much radio opaque, right? So all that you have to see within the internal structure. Okay, so that is regarding the internal structure. The third step being the internal structure of how you assess, right? So next thing is the fourth step, which is the effect on the surrounding structures. So how does it affect on the surrounding structures? The effect on the tooth, the effect on the roots of the tooth, the effect on the internal or cavities, or the effect on the cortical plates of the bone, the effect on the inferior alveolar canal. Okay, so how does it affect the adjacent structures, the abnormality? Even that you have to look for. And the final step is nothing but you have to formulate your radiographic interpretation, and finally you have to make your report. Okay, so the fifth step is nothing but the formulation of your radiographic interpretation. So first step, localization. Second step, assess the periphery. Third step, internal structure. Fourth step, effect on the surrounding structures, and last is the formulation of your radiographic interpretation. Right, now let's discuss from the dental caries. So first, here if you see, there is this radiograph. If you see, there is a proximal cavity, right? So that this proximal cavity is nothing but the dental caries. So there is a proximal caries, okay, which is seen here. So this, if you see, there is a already there is a filling or a restoration there. So below that you can see a radiolucency. So this is nothing but the proximal caries, probably the secondary caries. So this you have, it's quite easy to identify. But what is actually confusing is this condition. As you can see, it is marked in with an arrow. It's nothing but the cervical burnout. Okay, so cervical burnout. So you have to differentiate the cervical burnout with that of the proximal caries. So there is invagination of the proximal root surfaces which allow more of the X-rays to pass through this area, because of which there will be a radiolucent appearance in the radiograph. So that difference you need to find whether it's a cervical burnout or whether it is a proximal caries. So caries will be usually little haphazard, it will not be well defined like that, but whereas cervical burnout is usually well defined, and you can easily make it out that it's cervical burnout, which is because of more of X-rays absorption in that area. Because of the invasion of the proximal root surfaces, there is more of X-rays that pass through that area, giving the radiolucent appearance at that area. Okay, so that is nothing but the cervical burnout, and at times you can even find such type of findings, right? So that is again, even you can see there is a radiolucent band here. This is nothing but enamel hypoplasia, and even if you see here in this radiograph, there is a small radiolucent line which mimics caries, but it is not caries. Okay, here this particular radiograph, it is very, very important to underline. So cervical burnout and this radiograph is very, very important. Why? Because here the shadow of the alveolar bone is fallen over the roots of the molars, which is being given like a presentation has that showed a radiolucency over the roots, which is nothing but match band effect. Okay, very important, match band effect. So it's the shadow of the alveolar roots fall over the roots of the molars, having little radiolucency over the molars, which is nothing but the match band effect, which again mimics caries. Okay, so these two very, very important, the cervical burnout, which is again seen at the cervical area, and the match band effect. So this is the different aspects which actually mimic caries, but they are not caries. Okay, so these two do give a good glance to the picture and get the idea. Okay, so that is regarding the dental caries. Next, coming to the periodontal lesion, which is nothing but the aggressive periodontitis. If you see this picture, so now a radiograph is given to you. How will you know whether it's aggressive periodontitis? Because there is a bone loss, or if you see, there is a defect that is seen only at the molars, right? In aggressive periodontitis, usually anteriors and only molars are involved, whereas premolars are normal. And of course, the clinical case scenario should say that the patient is young age, but if you just see the radiograph, only the molars are involved, right? If you see, all the 4 molars are involved, which clearly says that it is aggressive periodontitis. Okay, so the defect or the bone loss is clearly depicted in the molars, so that goes in favor of aggressive periodontitis. Okay, so next, if this diagram, if you see, this is a axial section of a CBCT, for the first one. So you can see there are some extra teeth, which is nothing but supernumerary teeth, right? So these are nothing but the supernumerary teeth, and similar presentation of the supernumerary teeth is also seen with the tomographic image of the CBCT. Okay, you can see small denticle like which is resembling the teeth, right? So that is nothing but the supernumerary teeth. Okay, so this is one of the commonly seen dental anomaly, so you can simply find it out. Next, coming to the very important radiographic finding, I always actually in our daily discussions we have gone through this. This is nothing but picket fence appearance which is seen radiographically, and that is seen with the amelogenesis imperfecta, the hypoplastic type, because there is loss of enamel, because of which there will be loss of the contact point. So if you see, the contact points are not there, that is giving the picket fence appearance, and it is clearly appreciated in the anterior mandible. So if such a radiograph is given and you can see there is loss of contact areas and there is very thin enamel, then you have to go for amelogenesis imperfecta. So you can clearly see that the enamel is not at all appreciated here. So there is no enamel, because of which there is loss of contact areas, that is giving the picket fence appearance, which goes for amelogenesis imperfecta. Okay, so this is again one of the important dental anomaly and a radiographic finding that you need to know. So do underline that. Next, coming to the abnormality here. So if you, this radiograph is given to you and they'll ask you to identify what could it be. So there is a simple radiolucent lesion which is surrounded by a radiopaque border, right? So it seems to be something which is abnormal, but actually it is a developmental salivary gland defect. Okay, so it is a developmental salivary gland defect, and since it is not above the inferior alveolar canal, it is not odontogenic origin. It is below the inferior alveolar canal. So as we have come across the Sefni cyst and all that, right? So if it is abnormally increased in size, then it goes for an abnormality, or else it's nothing but a developmental salivary gland defect, okay, which occurs below the inferior alveolar canal. And if it rapidly increases or if it is much bigger in size, then it will displace the superior alveolar canal, or sorry, it displaces the inferior alveolar canal superiorly. Okay, so if it increases like if it is a bigger in size or if it increases in size, then the canal will be displaced superiorly. Okay, so that is regarding this particular diagram. So there is no much abnormality, so you have to simply go for a developmental defect. Okay, now this diagram is given to you. So whether they can ask you what is it, identify it. If now you see there is something seen with the within the maxillary sinus, and whether it's odontogenic or not. Okay, so if you see here, it is not odontogenic, it is within the maxillary sinus, and there is no particular corticated border which can be appreciated. So it is nothing but a pseudocyst. Okay, so it is a pseudocyst which is found within our maxillary sinus. So just what you have to see, you have to localize first. The internal structure is fine, and you can see there is no particular like any border that is clearly appreciated, right? And also you have to see the epicenter of the lesion. So epicenter of the lesion says that it is not odontogenic. So you have to go for a cyst or a pseudocyst which occurs or which is occurred here in the maxillary sinus. Okay. Now let's see this. So here, if you see this radiograph, there is some abnormality that you can find, right? So first you have seen the abnormality. First is you have to localize. Yes, it is localized and it is in one surface of the posterior. It is starting from the anterior and it is also involving the posterior. Okay, so it is in the mandible, right? So that is number one. Next, what did we discuss? We have to see for the margins. So margins, if you see, there is some radiopaque border which is like scalloped. Okay, so the shape of this is scalloped. Okay, next we have to go for the internal structure. So internal structure, you can see some septae with here and there multilocular appearance is there, right? And fourth step, as we discussed, is you have to see for the effect on the roots or the effect on the adjacent structures. So effect on the adjacent structures, not much of the effect is there, right? So this goes in favor of OKC. OKC, very important findings is it has this scalloping. Okay, so very very important, and also it will not show any much of the effect on the adjacent structures. So there will be not much resorption of the roots, okay, or there will be not much expansion of the cortical plate, especially the buccolingual expansion will not be there, only the anterolateral expansion will be there. Okay, so this goes in favor of OKC. So if you see the scalloped margins, directly you can go for OKC. It's a very important finding for the OKC. Okay, so it is scalloped, right? So this is regarding the OKC. Next, coming to the one more finding. Now this radiograph is given. First step, localize. So where is it? It is, yeah, it is near to the tooth, but if you clearly observe, it is with the mandibular canal, right? So there is some abnormality with the mandibular canal. So here the first very step identifies that it is within the canal. Okay, so the canal, the finding is within the canal. So it is a neuroma or some abnormality which is seen within the canal. So the question can be asked, if you see this particular picture, so because if it occurs, why it is, you must have got a doubt of why it is neuronal or why it is nervous in origin, why it is within the canal. Why? Because if it is odontogenic, the canal will be displaced downwards, right? If it is something developmental salivary gland defect, as we have seen the other picture, the canal will be displaced superiorly, right? Here the canal is in its place, and the abnormality, the radiolucency which you have seen here, has originated from the canal, right? So that says that, so the localization of the abnormality takes its first place. Why? Because epicenter of the lesion itself decides what exactly it is. Okay, so this goes for something abnormality which is neural in origin. So if I am an examiner, I can ask you a question, there is an abnormality with the radiograph, say its epicenter or tell its origin. So whether it's odontogenic, whether it's salivary gland, or whether it is non-odontogenic, or whether it's nervous or neuronal origin, then you have to go for the fourth option, okay, because it is seen with, associated with the mandibular canal. Clear? So this is a important thing again. Okay, now next, coming to the other abnormality. Now if you see a radiograph that is given to you, so almost the molars, if you see, there is a radiolucency which is surrounded by a haphazard radioopacity, right? So first localization, yes, the molars, almost the molars and the premolars are involved. Second, again periphery is ill defined, it is not that well defined. Third, internal structure, so if you see, it is more of mixed type of thing, right? And again the effect on the surrounding structures. So effect on the surrounding structures, if you go with the tooth, you have to see for the lamina dura, you have to see for the periodontal ligament space. So if you see here, there is loss of lamina dura continuity, there is widening of the PDL space and all that, right? So this goes in a favor of diagnosis, which is nothing but it's a mixture of rarefying and sclerosing osteitis. Okay, so because it is little haphazard, it is not confined to one tooth, so it goes in favor of mixed rarefying and sclerotic or sclerosing osteitis. Okay, so rarefying and sclerosing osteitis. Okay, so this is regarding this particular radiograph. Okay, hope you are getting through this. So it's nothing, it's quite simple. Whenever a radiograph is given, draw your 4 steps. First one, localize the, like give your locality. Second, periphery. Third is the internal structure. Fourth is the effect on the surrounding structures. If you see via all these 4 steps, you can simply arrive at your diagnosis. Okay. Next, now if you see this particular picture, it clearly shows us something with the condyle. So the condyle is supposed to be like this, right? But here it is like this, as if it is sharpened. So first thing, localization. So this is condyle. Second, shape, periphery and shape. This is the periphery and shape. The shape is not normal. It appears to be little sharpened, right? Third, internal structure. There is nothing much to know in the internal structure. Okay. So here if you see with the second step itself, you can see that the shape of the condyle is not normal and it is like sharpened. So sharpened pencil appearance. It is clearly with rheumatoid arthritis. Okay, so they can simply post a picture like this and ask you to arrive at the diagnosis, radiographic diagnosis. Then you have to go for rheumatoid arthritis. Because of the sharpened pencil appearance, you have to go for rheumatoid arthritis. Okay, so this is again related to TMJ, which is again quite important. Now next, coming to the malignancies. So malignancies is not not that important as per the radiograph, because clinical findings of the malignancies play a very important role. Okay, so clinical findings have to be given, but besides that, if you see the radiograph also, you can arrive at a diagnosis. So for malignancies, if you see, there are different types of presentation which is given by malignancies. So the first one, if you see, okay, this one, they are ill defined invasive borders. So there is invasive borders causing bone destruction again. So this is first. Second one, showing the destruction of the cortical boundary. Okay, if you see, there is destruction of the cortical boundary, and also it is invading into the soft tissue. So there are different findings which is being given to how to identify a malignancies. So the first one, ill defined invasive borders causing bone destruction. Second one, destruction of the cortical plate and again perforating into the soft tissue, or means going into the soft tissue. Okay, so third one is invasion of the tumor along the pedontal membrane space, okay, causing irregular thickening of the space. So if you see the third one, it is invading into the pedontal ligament space and causing the irregular thickening of this space. Okay, so it is actually that difficult. I mean, it's not that easy to identify in a radiograph. It is little difficult. So clinical findings are actually important for malignancies, but yet these are the different findings of malignancies in a radiograph. So I have posted all of them just for your idea. The first one we have discussed. Second one is perforation of the cortical plate. Third one is the invasion, or the tumor will invade along the pedontal membrane space, causing the thickening of the pedontal space irregularly. Okay, if you see the fourth one now, there is multifocal lesions. Okay, so there is not only one lesion, there are multifocal lesions, right, which are seen at the root apices. Okay, and also it is seen around the developing crypt. See, if you see, there's a few teeth which are still developing, right. It's also seen with the developing crypt, and also you can see the displacement of the developing tooth. So this is one of the finding of the malignancy. So there are different findings. So malignancies will not have a one particular or a peculiar picture. It can be like different types. So all these I have discussed. So first one is like it can be simple invasive. Second one, it can either like perforate the cortical plate. Third one, it can like invade into the pedontal ligament space and cause the irregular thickening. Fourth one, it can have a multifocal appearance displacing the tooth. Okay, and also if you see now the other, so like this particular picture, just I want to post you to show this one. Okay, so if you see here, there is complete destruction and you can see the sun ray appearance. So this picture, it clearly shows the sun ray appearance. Okay, so the bone destruction around the existing teeth, and again it produces a rays locus, like it produces like rays. Okay, if you see, the bone destruction occurs and it shows this rays appearance, which is a sun ray appearance. We know the sun ray appearance, where do we see? We'll again show the picture regarding that. So this picture I've posted only to say or to show the sun ray appearance. Okay, and this picture, if you see, there is a severe bone destruction and the teeth appears to be floating. Okay, this is also one of the important finding of a malignancy which occurs in the jaw. So there is severe bone destruction and the teeth appears to be floating. Okay, so it will be like a floating teeth. Okay, so all these are the different findings of a malignancies which can be depicted in a radiograph. So now this is a radiograph that is given to you. Now how will you identify like whether it is a malignancy or not? Okay, so the first step, localize. If you see, yes, it is occurring in the jaws. Second, periphery. If you see, it is very, very ill defined and there is a sun ray appearance, right? Third, internal structure. It is so haphazard, it is mixed type, right? Fourth is nothing but it's adjacent structures, its effect on the adjacent structures. So if you see, the teeth are little displaced, right? And since it is osteosarcoma, there is sun-ray appearance, the cortical plate is here, it appears to be normal, but if you see the CT image, there is little loss of the cortical plate as well. Okay, so this goes in favor of osteosarcoma. So directly if you see this radiograph, because of the sun-ray appearance, it's pretty clear that it is osteosarcoma. Okay, so this is how you have to arrive at a diagnosis when a radiograph is given to you. So it could be a simple dental caries, right, or a pedontal lesion, or a TMJ related lesion, or a cyst or a tumor, or a malignancy, okay, so, or a developmental anomaly. So it could be anything, the abnormality could be anything, or any of the diseases that you have studied in your books. Okay, so just thing is, you have to go in a stepwise manner. If you go in a stepwise manner, then you can be pretty sure that you can arrive at a good radiographic diagnosis. Obviously, you have to again correlate with your clinical findings to go for a good diagnosis, but yes, if a radiograph is given, in order to arrive at a proper radiographic diagnosis, this stepwise manner of analysis of a radiograph or interpretation of a radiograph is quite important. Okay, so after this, try to solve as many radiographs as you can. So go through the radiographs wherever you find and try to give your radiographic diagnosis based on that. Okay, thank you.